In our presentation today, I've asked a friend of mine, Michelle Hayes, to sit in and be online with us. Michelle has worked with me for 15 years, I guess, and over a period of time being a licensed medical esthetician, she has opened or started 8 different practices with dermatologists and plastic surgeons that she's been involved with the practice. So she's a valuable source of knowledge for not just how to take care of skin problems, but how to market a practice, how to start from scratch and get people coming in the door, waving their $100 bills, wanting to know how they can find out better ways for taking their practice or their business to a higher level. So I welcome Michelle to be here with us today, and from time to time I'll ask her to give her expertise as we're going through the presentation. Anyway, I'm plastic and reconstructive surgery. I'm retired from practice now because I just love doing the research and development that I've been doing for the past 25 years actually. And I love to teach. I love to teach others how to give better care to their patients as they develop their practice years, younger folks, as well as to help folks take care of difficult problems at any time in their practice. So follow along with us and let's have a good time. Take notes and write your questions down. We'll try to answer them when we get to a point to do that. I will make some disclaimers. First, I'm paid by Therapon Skin Health. My focus is on research. I don't really know anything about selling stuff, so I'm not going to sell anything, and I'm here to teach today. I welcome your questions. They're always important. In my practice, seeing new patients, my first statement to a new patient was, I want to know what it is you would change if you could change anything, and there's no such thing as a stupid question. So all questions need to be answered to get the best result. And as I mentioned earlier, you can email me. I won't be able to answer them during the presentation, but certainly afterwards and at any time, jbeckman@therapon.com. What we want to talk about today are some common skin conditions, but yet those conditions that can be very, very difficult to take care of. Obviously, aging is something that all of us are going to experience sooner or later. If not, well, the alternatives haven't been very kind to us. But aging is a process. It starts at the moment we're conceived as an embryo, and it continues and causes predictable changes that show up visibly when we look in the mirror. And those are commonly called wrinkles, fine lines, dehydrated dryness of skin. Sun damage is a cumulative thing. I like to think of it in terms of incremental aging. We start getting sun damage as a child when we play outside in the sandbox, and the damage that occurs incrementally each time we're in the sun is very small damage unless we have an acute severe sunburn, which we're aware of. But even if we just walk from the car into the office or into the grocery store, we're getting some sun exposure, and it's cumulative. And over a lifetime period of time, it develops into pigment changes, melasma or uneven pigment, and actinic keratoses or sun damage to the skin cells themselves. We have acne as rosacea acne, which the rosacea means red color, and it can be with or without pustules. In other words, the acne portion of that is because it is in that group that group of conditions that can clog pores, and we see frank pustules and acne breakouts from it. Then we see patients with acne vulgaris, which is vulgaris actually refers to the common person. And I think the statistics are that 90% of persons in Western society will have some breakouts, some episodes of acne at some time in their life. That's 90%. So all of us are going to have problem skin from time to time, some much more severe than others, and we'll talk about some of those that have blemishes and a recurrent problem skin condition. And then atopy or atopic skin are those skin types that are very sensitive, they're very allergy prone, and they have a special set of conditions that we need to be aware of when we're seeing them for skin problems as well. Now, it's always important, just like I mentioned a while ago, that every question is important. I think when patients come to see us, there are some critical first steps. We need to ask them questions. We need to ask questions about their skin, about their skin history, perhaps even their diet and medical history, as well as do an analysis of what their skin is at the present time. In other words, if they're asking us to answer questions about a skin condition that's current when they come to see us, we want to know all the information we can about their history and their skin type, anything that they might be allergic to or sensitive to. And it's critical that we get as much information as possible on that first setting. Now, I mentioned that the aging process is a cumulative sort of thing. It starts early in life. What we don't realize is that our outer surface of skin, the epidermal cells, are those cells where pigment cells, the melanocyte cell group is. Those cells divide at the basal layer and push a cell up, and then again divide at a later time and push another cell up, and those cells kind of bubble toward the top until in the upper third of the epidermis those cells become dry, dead cells, and pigment is dispersed out into the stratum corneum. And every day there's minor abrasion as our skin rubs against the surface. Just a washcloth, for instance, causes some mechanical abrasion, and some of those surface dead cell remnants fall off or shed. And that process, from the time that cell is divided and bubbled up to the top, we call it turnover time. So cell turnover time at a young age, preteen age, is about 2 weeks. So every 2 weeks we completely replace our epidermis. Now that's a lot of growth, a lot of development, and a lot of things going on. If everything works well, it works like a finely tuned clock. If there's a disease process or an abnormal condition, then it interferes with that. However, by age 30 or about age 30, that cell turnover time has slowed down. It's a normal process of slowing down, and from 2-week turnover time to 6-week turnover time at age 30 is not uncommon. This increases, the slowdown turnover time increases to about 13 weeks by the time we're a truly mature, almost ready to retire 60-year-old person. I passed that milestone some years back, but what happens if cells stay in place for 13 weeks where they used to turn over every 2 weeks, instead of those bright, ruddy cheeks with a fresh skin color that we see in a toddler or a preschool child, at age 60, those extra layers of skin cells have hung around and built up layers that are dry, dead skin cells that have a yellow, dead, sallow looking color to it, so we lose that brightness. That's why women hundreds of years ago used to use natural botanical products to put on their skin to make them look younger. Uh, I think vanity probably started in the Garden of Eden, where there was probably a pool of water and Eve looked in it and thought, oh gosh, I don't look the same as I did last month. So anyway, that aside, I think we all look in the mirror and we notice things as we get older. And a lot of what we notice is due to the cells being there for a longer period of time. Now, we can do things on a daily basis that improve our skin health, and that's commendable. Some of the things we're going to talk about later in this webinar will be things that are procedures that you'll be doing in the office. But as a daily regimen, if you don't do anything to skin, the upper photograph where it says untreated skin, both these photographs are pure epidermis, and the honeycomb looking portion on the top picture is what we call the basket weaving or honeycomb stratum corneum, and that looks loose and fluffy and not very solid. But over a 12-week period of time, using an alpha hydroxy acid on a daily basis, it's caused those cells to exfoliate down to a compact, thin, tight layer, as we see in the lower photograph. We also see an improvement in the purple or pinkish cells in the lower photograph that have a lot more distinguishing defined cell borders. So that's telling us that something that causes exfoliation causes an increase in the health of the cells and the structure of the cells underneath. If we could look even deeper than these pictures, we'd see new collagen being deposited down in the dermal layer. Now, premature aging is something that we'd like to avoid. We can't avoid aging without dying, and that's not a good alternative. But some of us get more sun than others, and we have premature aging changes, and we classify those into wrinkling or surface aberrations that could be fine lines or even more coarse wrinkling. We lose the ability for retaining moisture in the skin, so we get a dryness to skin, and we evaporate more water as the barrier, the moisture barrier in the epidermal layers becomes depleted, and we actually get dehydrated. So we get a dry, cracked, and or wrinkling of the skin. And the best first line defense is those things that your patients can do at home. Whatever the renewal system you're using, it should have something that causes an increased cell turnover or an increased exfoliation. We like to use a moisturizer that's enriched with a lanolin base. Lanolin is an animal oil, where vegetable oils and mineral oils don't absorb into the skin. Lanolin, being an animal oil, does absorb into the skin and very naturally approaches the lipid consistency that should be present in normal skin between the cells. So that helps prevent the evaporative portion. Peptides that rebuild the collagen matrix are important and available. There are a number of peptides available that skincare companies put in their products. We like to think that our Eternox peptide cream is superior in that we use a particular peptide, a group of peptides, but one in particular is available only through our products, and it's a peptide that was developed for healing wounds that had actual skin loss from burns or military injuries. It's covered by 31 different patents, but it actually increases the collagen content in skin as well as the thickness of skin. There are other peptides available for special purposes like eyelids or lips. We like a sunscreen that's a broad spectrum sunscreen for both UVA and UVB protection. UVA spectrum of ultraviolet rays pass through the epidermis down into the dermis and cause free radical damage, which causes destruction of collagen and elastic fiber. And that gives thinness to skin, it gives laxity to skin, whereas the UVB rays are almost completely absorbed in the epidermis. And those are the cells that give rise to skin cancers. So 99% of melanomas, basal cell carcinomas, and squamous cell carcinomas arise in the epidermis, and they're caused primarily by UVB. But we can do some things to skin to reverse damage that's occurred in that premature or aging skin. And we're going to talk about some of those things. If you look at the photograph of this young lady on the screen right now, we start to see some forehead wrinkles, horizontal wrinkles. We see some early glabellar or above the nose between the eyebrow, those frown wrinkles I call it, and we see some pigment irregularity. And what we want to do is help that. We can very easily correct many of those minor fine lines with superficial peels. These are what we call little lunchtime peels. Lactic acid, glycolic acid, all of the alpha hydroxy acids are designed to work in that superficial epidermal layer. They should not remove epidermis, so there shouldn't be a downtime or a healing time. I have a distinct preference for lactic acid in these peels, and that glycolic acid is not metabolized by the body. It has to be excreted as crystals by the kidney and can cause actual damage. But usually we'd use the alpha hydroxy peels in a series, either weekly or bi-weekly, for maybe 5 or 6 different peels in a series, and we can get a very nice result both in improving the distribution of pigment in the skin, diminishing the fine lines or wrinkles that are in skin, and along with the pre and post peel products, we improve the hydration or the dryness component to skin. We mentioned pigmentation. Irregular pigmentation is a significant problem. If we're completely evenly tanned, that's thought of as beauty. If we're completely evenly albino, it's still a whiteness, or it's relatively easy to camouflage makeup over an even pigment base. When we have irregular pigment, it creates a different problem. Now, pigment is formed at the basal layer of the epidermis by melanocytes. In little portions of the melanocyte called a melanosome, the pigment is created, and then it's distributed through little tubules from the melanocyte into 20 or more other epidermal cells that don't have pigment production capacity. So it acts like a fuel truck fueling the cells with pigment that are around it. So pigment gets evenly distributed normally in all the cells in the epidermis in the lower levels. And as those cells grow upward toward the surface, about mid-level in the movement up, those cells start to burst and to die, and the pigment is evenly distributed in the mid to upper dermal or epidermal layers of cells. So the pigment that we see in this photograph for this patient is pigment that's not inside living cells. It's pigment that's been distributed outside living cells. And if we used a hydroquinone or a melanin suppression agent, that pigment would still be there unless we exfoliate it off. We can suppress new pigment from forming, but to correct that pigment problem that we see or that she sees in the mirror, we've got to do something stronger exfoliation than just speeding up that cell turnover. We would use the treatment products as listed on the left with all of those things that are daily maintenance products. But procedure-wise, I would start this lady on a number of things before the treatment procedure. We want to suppress the melanin. We want to use some exfoliation agent on a daily basis for at least 2 weeks to stimulate those cells to turn over more rapidly. And in this particular patient, I would do a frost peel, chemical peel, using either 2 layers of 20% TCA over 1 layer of Gessner's, or a single layer of 30% TCA over a single layer of Gessner's. And this will have some downtime, but in a 3 to 5 day period of time, this lady should be able to easily cover with makeup and have normal social activity without any significant downtime. So that's the irregular pigmentation with no other additional problem. Here's another example, different patient side view before and after that can be improved with superficial peels, but would do better with a 15 or 20% TCA peel. Here's a close-up, same lady, but after a 20% TCA peel. There's an improvement in the smoothness of skin, or the diminishing the fine lines and wrinkles, but the major benefit is in the irregular pigment becoming more regular. Now another one of those common conditions that we see, and I think we're seeing more of it in Western society now than we did 15, even 10 or 15 years ago, and that's called rosacea. And rosacea is really a disease of small blood vessels, the capillaries. And when capillaries become weakened and they dilate, it lets more red blood cells into the dermal portion of the skin. And if you have more red dots per inch in a picture, the picture is darker red, or the redness shows up. And what we normally see with rosacea is not irregular spots, but pretty much symmetrical. The cheeks and the nose and the forehead are the areas most likely to be involved, although we do see it down in the neck and other areas of skin. But it's very difficult, if not impossible, to cover red with traditional makeup. Now, mineral powder makeup works well to cover, but if you forget your mineral powder, or let's say you go to the beach and go in swimming and your mineral powder comes off and you come out with bright red face, you're not embarrassed to cause the redness, you're embarrassed because of the redness. That's not a happy camper feeling. So what can we do for acne rosacea that's non-pustular, that has flushing only? And I mentioned the flushing because most rosacea patients do have some subtle redness to their skin, but if they drink hot liquids, eat hot peppers, or sit out in the hot sun, it tends to dilate capillaries and you see more redness, or more predominant redness. And in these patients, they respond well to a series of superficial peels. Usually the Gessner peels are more significant in terms of improvement. I would wait 2 weeks in between each peel in a series of 5, as opposed to a weekly peel with a lactic acid or alpha hydroxy acid. And then after that series of Gessner peels, we always want to evaluate and see if additional series or maybe even additional types of procedures can benefit. So that's the acne rosacea that has no pustular damage, but purely the vascular component of it. And we can see a very nice result after six peels done a couple of weeks apart with lactic acid in this lady's skin. She does have some makeup on and a little different lighting in the view on your right-hand side on the screen, but her skin is very much more uniformly colored. So if she didn't have on makeup, it wouldn't be as noticeable as it had been before. Now, acne rosacea also can have pustular activity, and that's really where it got the name, or gets the name, of the acne rosacea. In other words, the acne component is clogged pores, along with the redness and the flushing and the irritation that's there. We'd use the same treatment products that we'd use for skin health, but we may add the reversion clear skin system, which actually includes some salicylic acid, benzoyl peroxide, and other ingredients that are more effective for true acne breakouts. But as far as procedures, I still think the Jessner peels done in a series 3 to 4 weeks apart, perhaps even, will give significant result from pustular rosacea. And when it's very mild, those Jessner peels, 1 or 2 layers of Jessner solutions at a 3-week interval, almost always will correct things. When there's a single breakout or monthly breakouts that are many times experienced by young women on that monthly cycle, where there's just a single breakout, you can feel a red spot, tenderness, and you just know by experience that tomorrow it's going to be a problem area. Using the reversion spot treatment the evening that you first notice that tenderness oftentimes can prevent that picture from happening that's on the left-hand side. Now, acne is difficult in its mildest form, but actually there are 4 different categories of severity of acne. The moderate is more than 8 to 12 lesions present, with some being actual pustular lesions. The 4th level, the most severe level, is actually subcutaneous tunnels or cysts that form. Those are very difficult to treat. They're much more easily prevented if you can get your patients at an earlier age before they've had long-standing disease. I think Michelle may be able to add some helpful information on what her feelings are with oily skin conditions that have very moderate acne vulgaris. Michelle, are you able to add a little bit to this conversation?
Well, with the acne vulgaris in a moderate condition, one thing I always look to is how sensitive their skin is. Sometimes this condition has made them so sensitive that I have to back up a little bit and offer even the more milder treatment plan, maybe for just a couple of weeks of at-home maintenance with using cool temperature water, making sure they're staying completely out of tanning beds and as limited UV exposure, and using some mild products for about 2 weeks, and then have them return to the clinic and offer some assistance as far as either some deep pore cleansing facial treatments, or maybe moving into having a light chemical peel treatment. But again, once it gets into this moderate stage, I just like to look at how sensitive the skin actually is. Now, if they're not a real sensitive skin type, sometimes we can go ahead and work with a deep pore cleansing facial. I can send them home with a pre-treatment kit and tell them that we are going to proceed with a chemical peel within that next 10 days to 2-week time frame.
Those are excellent comments. I think I would add to that, once we get past the 2 weeks of basically letting the skin heal itself as best it can, when we see that patient back that has active pustules, sometimes the superficial peels, Gessner peels, will unroof those pustules and allow that to heal. But you ought to give a 2 to 3 week period of time in between Gessner peels to allow healing from the depths. Then
Yeah, I totally agree with that.
the really severe, I think everything we said earlier is holds true in all degrees of severity. But these are those patients that you need to get your doctor involved, or at least that patient's physician involved. They need to be under care of physicians. They probably need to have an antibiotic from time to time, and they also may need to have procedures done that would include lancing the skin, draining of cysts, things of that sort that are going to get us in trouble if we're not licensed by the appropriate medical board for doing those things. But I guess my advice to all of us would be is these poor people that suffer from these extreme conditions need your support and help. Don't just write them off and say, I can't do anything about this. If nothing else, spend 5 minutes every couple of weeks just listening to them and encouraging. Acne occurs on the body as well, and not just in men. Uh, we see it a lot in athletics. Football is an example where guys are wearing shoulder pads. They're wearing the same shoulder pads day after day, and they have acne breakouts. Uh, so we got special areas that may need some special treatment depending on body habits and hobbies and things of that sort. But frost peels, the chemical peels with 20% TCA work well on the thicker skin of the back. The skin of a 17, 18-year-old football player guy may be a quarter-inch thick, and that's a big difference than the thickness of the eyelid skin that's half of a thickness of a piece of cardboard. Uh, so don't be afraid to use your peels as tools, but just like you're hanging pictures, you don't use a sledgehammer to put a nail in the wall to hang a little small poster on. Use a tack hammer when necessary, but use a bigger hammer when you need to. Now, allergy prone is a common term that we hear, but it oftentimes is mistakenly identified as purely sensitive skin. Michelle, what's been your feeling with hair color, eye color, skin type, and sensitive or allergy prone skin?
Well, this particular picture right here is very indicative of those people that walk through the door, and I feel like before I ask them a question, I've already identified them as a sensitive skin. The redheads that generally have that snow white skin, freckling, a little bit of freckling, they almost always have very sensitive skins. Blondes, blue eyes, their skin is just a little bit more delicate, and they will usually be able to talk with you about allergies that they have not only to products but to foods or seasonal allergies. You have to do a lot of consultation with them. They're usually very frustrated patients because they've used so many different products and have just simply had poor experiences. I will say that Theraderm is just an excellent product to be able to hand out with the gentle moisturizer and know that you're going to give these people some products that they're going to see a difference and feel a difference within about 10 days to 2 weeks, and just not have to go through experiencing that discomfort and so forth. But it really is indicative of that lighter complected skin most often.
Most patients that do have allergies or sensitive skin are usually aware of those triggers or those things that kind of set them off. How do you approach, or let me rephrase this, when I see a patient that comes in and says, well, I'm having these breakouts and I didn't have them 2 weeks ago, but I started having some problems. I think it may be that I'm using this, or this topically on my skin. What advice would you have for a patient to identify and enable them to identify what it is that's causing their skin to be more sensitive or to develop the allergy symptoms?
Well, when I have that problem where they'll come in the office and um, say that they know they have sensitive skin, but they're exhibiting some problems. I talk to them about what products are on their skin all day, and the three things that I specifically point out is, have you changed your moisturizer? Have you started using or have changed your sunscreen, or have you started anew or changed your foundation makeup? Because those products are what's on the skin for the entire day. And I find that those are generally the culprit. It doesn't seem to necessarily be a cleanser, an exfoliator, or even treatment serums that are the problem. It always seems to hinge on the moisturizer, the sunblock, or a foundation makeup. And one of those usually seems to get a rise. Yes, I've changed this, or yes, I started using this, or this is a new product. What I generally have them do is discontinue everything. I will hand them a travel kit that's a 10-day supply of 4 basic products, just a cleanser, the fruit acid exfoliant, the OPC, which I know is just going to calm a condition, and then the gentle moisturizer. I have them use nothing but that for 10 days and come back in the office and report to me whether or not they're seeing an improvement or the condition has completely gone away. And in most cases, it has.
Those are excellent suggestions. I would add one other thing that I do. Uh, when a patient has said, well, I've been using this product and I think it may be this product or this regimen, 2 or 3 products in their daily maintenance. I think it may be one of those. I have them individually put one of those products in one spot inside the upper arm, another product in a different spot, same inside upper arm, different spot. And that way you're testing each one of those products to see if that might be the culprit. Because I think it's good for patients to know if there's an ingredient in one of those products that's caused their skin breakout or sensitivity, to know what that ingredient might be. And that helps them when they go to the counter and look at other products, whether it's makeup or other topical products, things to stay away from. But your advice is excellent. I think those things that stay on the skin all day long are probably going to be the culprits in causing the problem.
Mhm.
Now, for dryness, why does skin get dry, Michelle?
Well, it can be certainly seasonal. When somebody comes to me and says, my skin is so dry, the first thing I say, is that year-round for you, or is that just seasonal? Seasonal dryness, when the dry heat gets turned on in your home, in your car, and there's just no humidity in the air, the skin does take on usually a more extreme dryness than on average. Um, I feel like a lot of times too, people are just kind of addicted to those hot, long showers. And I do tell people to try and lay off the heat as well as the length of time that they're showering, and when they do get done, to be sure they treat that skin almost immediately, if it, without drying their skin completely, leaving it a little damp, to put those moisturizers on to help guard against the evaporation of water in the skin. And but most of the time the seasons do predict a little bit more. Of course, people that live in an arid environment, and also people that travel. If I find I've got people that are on airplanes all the time where there's about 30% humidity on the plane, they tend to also have very extreme dehydration in their skin.
Good. Well, that's a good combination of things to remember. I like hot showers. Makes my muscles feel better. Uh, but if we don't replace those things that warm soapy water washes out, we're even more dry later. So I think we also need in the cooler winter months or in altitudes where the humidity is low, we do need to add emollients back that actually restore lipid barrier and help with the dryness, the prevention of the evaporation that's there. Tell us about keratosis pilaris. You're the expert at taking care of minor things that bother a majority of people.
I had so many people come in the clinic and ask if there was anything you could do for the bumpy skin on the backs of the arms, which of course is known as keratosis pilaris. And it does, by the way, sometimes occur on the tops of the thighs or even the lower jawbone area of the face. And I started doing some experimenting quite some time back. When New Peel was new to me, I started using that on the backs of the arms. Myself and my daughter had the same problem. And when I would use the New Peel before showering, just using the product, just wiping it over the backs of the arms and rubbing it in for about 2 to 3 minutes till it began to ball up, then I would jump in the shower and do all the shower business and then rinse that off last thing. And then while the skin was still damp, I would apply the body restoration cream because it contained the lanolin, but it also contained a little bit of lactic acid. And so I would put that on, again, the damp skin, and I found that within about 10 days to 2 weeks, it would really correct that condition. And I wouldn't need to do that every shower, every day to maintain it. I could skip 2 or 3 days in between and go to doing that routine maybe twice a week, 3 times a week. I found that it was more effective than just using the cream by itself or just using the New Peel by itself. It seems like the combination, using the New Peel before you shower and then upon leaving the shower putting the body restoration cream on, really helped to correct that condition of keratosis pilaris. And I've told countless dermatology practices of that particular product grouping to correct that condition. It's just something that a lot of people have to deal with, but there's not a lot of solutions out there for it.
Good words. Those are the conditions that we wanted to talk about today, but I want to talk a little bit about marketing your practice. Um, some of those listening in probably are new or maybe working in a new practice environment. How do you have any suggestions for building a practice? And I know we don't have time to go into that now. I know you counsel people and consult with people all over the United States, and probably in some foreign countries too. It's one of the things you do as a consultation service and actually charge money for it. But every one of those clinics I've talked to that you've worked with have said, Michelle has helped us increase our business 25 to 50%. Is that something you still are available to help people do?
Absolutely. That's something that I just get the biggest charge from going in and working with clinics. They're all so different. Dermatology practices and plastic surgery practices. I've worked with bariatric practices. Um, I've worked certainly in the medical spas and in the day spa settings, and I just enjoy the diversity and working with all the different types of aesthetic clinics out there. I like to just kind of work with them about finding their own identity and what makes them different from maybe some of the competitors in their area. I just like for them to look at why people would choose them to come to. And a lot of that goes to the skills that they possess, the resources they have, the types of equipment, the types of product offerings they have. It's just it's something that I really like to work with them. So many times they don't necessarily know exactly how to get their message out there. Maybe they're just not comfortable yet with internet marketing, and there is so much you can do in that area alone. Working with having a blog, doing some e-commerce, and putting your business out there for sale, whether it be products that you're selling or gift certificates that you're selling, or getting out there that you host events, having clinic workshops to really show people one-on-one the different not only product offerings that you may have, but procedures that you have, equipment that you have. So there are just so many different ways to not only work with your own clientele, but to engage new clientele. And I love doing that, and I'm certainly available to help anybody at any time with that.
Well, I had mentioned my email address, jbeckman@therapon.com, earlier on. How would one contact you? Uh, are you
Well,
anonymous?
no, I am not. I am easy to find. I have a blog that is at theskinwitness.com, and on that blog there is a training and consultation page that you can go to that kind of shows what I can do for you and with you to strengthen your clinic or open a new clinic. I try to get on there and post different things as I'm inspired by clinics that I visit or people I speak to. If you'd like to just email me directly, it's pretty easy. Just go to skinwitness@gmail.com.
Well, thank you very much for letting us know how to find you. Now you can't hide as easily. I want to thank everybody for tuning in that was able to come and meet with us today. I hope we've offered some helpful suggestions. Uh, Hopefully we've created some questions in your mind, and Michelle and I both would like to hear from you. Uh, Let us know if you enjoyed the material in the webinar, if you thought we stink, or somewhere in between. We look forward to having another webinar soon, maybe January, before we can get it scheduled in with a busy season. But hopefully we'll see you again soon. Thank you.